okay. It's okay to interrupt as long as you remind me where I was, because I'm reaching that age where my memory's not as good as it used to be. And so that's the story. So we're going to begin. As I said, my name is Alan Steinberg. I am a geriatric, I emphasize that, psychiatrist. I de-emphasize that. That's a historical thing that I've learned to sadly do as a reflection of society, which still 30 years after being in this field has changed, but not changed enough. So while geriatrics has a stigma, so too does psychiatry. So the people that I work with and for are, in a sense, doubly cursed by this double stigma. I work with a team. I like to do different things. All my life, I have done different things during the course of a week. I'm not the kind of person who has an office with just patients come in, a nice couch. I would be on the couch myself if I had a couch. It's the truth. And so it's different days, different things. I do work in center each with a team of nurse practitioners, social worker. We do evaluations, treatment, diagnosis of mostly older individuals with what I like to call neuropsychiatric disorders. And we'll get into defining terms in a few moments. And we also work with their families pretty extensively in helping them on this journey of being caregivers for the folks that they love, and preparing them for what might be. Historically, I went into geriatric psychiatry. It was a bit convoluted. I started out at Mount Sinai. I started out at Johns Hopkins as an undergraduate, and that's relevant for the following reason. At Hopkins in the 70s, there was a revolution in the field of psychiatry. A new team had joined the staff of the Department of Psychiatry there, led by a gentleman named Paul McHugh, and he had brought a whole team together that were very interested in revolutionizing the notion of psychiatry, which has gone through what they used to call schools of thought, or in their mind also faddish lurches. Their field was, as they expressed it, we're the school of schools of thought. And they wanted us to be well-trained in every approach and bring to a situation whatever that approach required of us. They also gave us the sense, very clearly embraced, that we should embrace what for typical psychiatrists would not be considered psychiatric. And unfortunately, to this day, I still see that it has not changed very much. So to them, and they were true pioneers. Marshall Folstein was one of my mentors. You may have heard of him. The mini mental state exam is often called the Folstein mini mental state exam. And so Marshall and I were very close. This was as an undergraduate. I knocked on their doors, went down as a sophomore, said, I'm interested in psychology. I knew nothing of nothing. He said, come on in. And I shadowed him for about a year. Then they put me to work on some projects. I did consultations with them. I was an undergraduate, and observed this new field, or what they wanted to be the new field of psychiatry. It was not a psychoanalytic field. It was not a behavioral approach. It was not a biological approach, but rather it was a whole conglomeration of approaches merged into one, where they felt strongly that diseases that had been relegated over there to not our job, meaning, Alzheimer's is not our job, or anything that you can say traditionally would have been neurology, which is an artificial subdivision from psychiatry. It's not our problem. We take care of psychiatry stuff. Neurologists take care of neurology stuff. And the twain didn't meet, but rather we learned to embrace and say, no, those are our fields. But historically speaking, it goes way back into the 10s, the 20s, the late 1800s even, when psychiatry was going through one of those faddish evolutionary periods where Freudian approach became predominant or dominant. And the attitude was that when you discovered something like an EEG on somebody who arguably had a psychiatric disorder, we'll get into the definition of that in a moment, but arguably started flapping their hands and fell to the ground, frothing at the mouth, lost their urine, that was a behavior that was observable, was a psychiatric condition. But then all of a sudden somebody invented an EEG and plopped that on some of these people and saw that their brain waves were different. And psychiatry at that moment said, oh, not my problem. Neurology and psychiatry kind of split, and they took over that side of things. This is just a broad history. However, I would argue, probably fairly successfully, that we know more about the biological genetic roots of a disease like schizophrenia now than neurologists know about the biological or genetic or chemical roots of epilepsy. And psychiatry is no longer quite as willing to abdicate responsibility for diseases once, and using an old term, organic etiology is discovered. And so to me, my field of geriatric psychiatry comes from the fact that when I was exposed as an undergraduate to the fact that the real psychiatry, I call it real psychiatry, sorry, is that overlapping, the field that's interested me is that area in between what was traditional neurology. So I would not touch somebody with brain tumors. I was not trained in that. Seizure disorders, not my area of expertise. Parkinson's, yes. Huntington's, yes. Multiple sclerosis, yes. Alzheimer's, yes. Headache, I've chosen not to, but you could see if this line of reasoning was pursued, it would not be, and there was interest, it would not be inappropriate for psychiatry to also say, hey, we have to merge these things and look at it differently. Because think about headaches and how many different causes there are and how many different influences there are and how many biopsychosocial factors are involved and at play. It would be certainly appropriate for a psychiatrist to be actively involved in the assessment and evaluation management of headaches. But to date, most have chosen not to. Sleep disorders, another good example where many sleep disorders specialists come from the field of psychiatry. They also come from neurology. They also come from pulmonary. They also come from anesthesiology. There's territorial challenges and all of that political stuff. But notwithstanding that, I then go off to medical school at Mount Sinai. In Mount Sinai, I did the typical medical school training, but the training in psychiatry in the third year, which was a rotation like we do, was much different than what I had remembered from Hopkins. It was more traditional, more divisive, I would say. There was the psychoanalytical piece, which was huge, and then there were these biological people over here, which was a little different. They wanted to know what's wrong with people with schizophrenia from a dopamine point of view. So it wasn't about syndromes or diagnoses. It was more like a reductionist perspective. Let's kind of try and figure out what's wrong with people with schizophrenia biochemically. And I wasn't enamored of that. So I said, I'll be a real doctor and I'll do internal medicine, because that was punting the can down the road. It opened up the most doors. And so I decided to go and become an internist and go do internal medicine training. So in the middle of my internal medicine training, I looked around, and this was like the wake up, and I said, this is interesting, because most of what I am seeing day to day as an intern, which was just an awful experience nonetheless, was what I thought the psychiatrists were doing down at Hopkins that I remembered as a sophomore and a junior, and that was Marshall Folstein with them. It was delirium, it was dementia, it was depression. And sad to say, that situation is still the case. You go into a hospital now, most of what internists are dealing with is, unfortunately, older folks, we'll talk about that, the 3 Ds of geriatric psychiatry, delirium, dementia, depression, but they're internists who are kind of struggling and managing. Now, they may see it through the window of the person is uroseptic, the person has pneumonia, we see it through the window of, yeah, but that pneumonia in that 75-year-old has caused an acute confusional state, which is really the problem that you're facing, is that they have delirium, which we'll talk about some more later. And that's what we have to struggle to identify and to treat a little bit better. Now, getting back to the geriatric psychiatry piece, we have to talk a little bit about the definition of geriatrics. Because we use words, and I talk a lot about words, and I think that foundational language is very, very, very important. And we use words without thinking about their meaning. So we start with the definition of geriatrics. And this is well, you guys are lucky, whoever you are, wherever you are out there. These guys are unlucky because they're going to be called upon. So the question is, what's the definition of geriatrics? So who wants to volunteer? That's because I'm going to pick on you if you don't volunteer. So somebody volunteer the definition of geriatrics.
The study of older.
How much?
The study of older people.
Well, then what's older?
Yeah.
Anybody who's 1 year older than me is geriatrics. I mean, is that our definition, right? So what's right? Even a simple word that I just said, I'm a geriatric psychiatrist, but I didn't even define for you what geriatric means. You have an idea, you have a notion, but you can't put it in.
Well, there's an age placed on it, similar to pediatrics, which refers to children or adolescents. So geriatrics.
It's an age-based.
For people who are older, but they, there's an age.
But what's the number?
How old?
18 is the line for pediatrics, right? You're an adult, arguably, when you're 18 by law or regulation.
No, New York State says 60.
It does?
Yes.
Do you mean I can get a discount on everything now?
Everything. 50.
I'm sorry, the talk's over. I'm going to, who do I have to go to?
Dunkin' Donuts.
Dunkin' Donuts. Excellent. I can get a discount at Dunkin' Donuts.
Free donut.
But they don't tell you that. Dang. Oh, man. All right. So 60. Now that is crazy. But let's put that aside.
I agree.
All right. Right. So the traditional definition, I think, or we've learned the traditional, came probably from Medicare, which comes from the 1960s, where they said you get Medicare when you're 65, most people. And why'd they choose 65 back then? Because
old age.
It was old, and most people didn't live to 65. So actuarially speaking, it was a leap, and we didn't have that many. Now, I would argue that the average age in my practice is about 91. And so when I see a 65-year-old, I'm looking at an adolescent. I mean, this is really a young person.
Yeah.
And so I don't understand the stigma associated with the number. I think the number is meaningless, except legally. I have 55-year-olds, I have 40-year-olds who are in worse shape medically than some 90-year-olds that I take care of. And that number, in my experience, is only used to hurt a person. But doctors are taught right from the get-go, when they do an interview and they have to write it out or now type it out. I was asked to evaluate this blank year-old. It's almost the first thing we're taught. It's in our book, this blank year-old. Why? It's meaningless, except to hurt them. Because I say they're 90, all of a sudden my brain starts thinking certain things. Well, unfortunately, or fortunately, I think we have to move away from that. So, but the tradition is, I take care of mature adults. I'm an immature adult, so it's okay. I take care of mature adults, whatever that means. I had a friend come from Eastern Europe, and he said, what do you do? I don't remember. You do something with old people? I said, yes, I take care of geriatrics. And he said to me something like what you just said. Oh, you mean people over 62? And I said, huh? No, most of my patients are much older, 80s and 90s. He goes, we don't have any of those. So the truth of the matter is, in a weird way, we're the byproduct of our success in caring for people into their later lives and caring for people well with diseases that used to do them in much earlier. I mean, my grandparents didn't live into their you know, 70s, 80s, 90s, or whatever. And if you look at pictures of, as an example, Franklin Roosevelt, when he died, well, when he was at Yalta or wherever he was with Stalin and Churchill, he looks like death warmed over, and he was 62. I mean, the man looked like he was 140. Now, granted, he was chain smoked, and he drank like a fish or whatever, and he had high blood pressure that was like way up here that was never treated because they didn't have treatment for it. So he was probably having little strokes and coronary artery disease, et cetera, et cetera, et cetera. But the bottom line is that is not a thing of the past necessarily, but we're managing it better. So I just want to emphasize to you that the notion of geriatrics has to be put into some sort of funnier place. And the expression I like is from a Regina Spektor song. You probably know who she is. You probably know who she is, maybe. You guys probably don't. Maybe you do. So there's a song on the radio, and there's one line that I just love, which is, "You're young until you're not." All right?
I flipped the camera.
So I have to...
No, you're good. But the writing is right.
Okay, the writing... Oh, hello. Okay, everybody. So you're young until you're not, and that's really kind of my catchword and expression and phrase, because that's the bottom line. And we shouldn't allow ourselves to be biased by the number. So that's number one. Number two is psychiatry. So we don't really know what the definition of geriatrics is, as I just said, although we have a legal definition. The Medicare 65, Dunkin' Donuts is 60, whatever. Then we move to the issue of psychiatry. So here it gets a little trickier, and I just don't want you to feel bad. But when I give lectures to psychiatrists, I ask them the same question. So don't feel bad. What's the definition of a psychiatric disorder? And they do not have the ability to tell me. So you can volunteer. Please take a stab at it.
Pathology that affects the brain.
Well, then what's a brain tumor? Would you then say that's a psychiatric disorder?
That affects the brain and behavior.
Okay, so now you're exploding it
Okay.
out a little
Okay,
bit.
so, and
Okay,
behavior.
but would you still say, you would simply say the brain tumor is causing psychiatric symptoms,
Correct.
but you would not say it's a psychiatric disorder,
Correct.
right? Okay, but
It's a medical disorder that's creating a psychiatric.
right, symptoms,
Right.
right? So now we're moving a little bit. You want to try Yvette? That's Yvette over there. Just everybody, yeah, she's
The
from
famous event.
the famous Yvette from the ombudsperson program. Okay. Anybody want to else throw in a little bit of a definition for us? Yes.
A condition that also has some chemical imbalance in the brain and affects the behavior and functioning.
Okay, so now you're being a reductionist by using that famous phrase, chemical imbalance. And I don't know what chemical balance is, to be honest with you. So it's hard for me to say I have a chemical imbalance. And I will tell you that people who speak along those lines, not you, but the scientists who do, will talk about chemical receptors, neurotransmitters, dopamine, blah, 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 blah. And I can go on, and I will simply give you my answer to this, which is what we don't know is far greater than what we do know. So I will hardly ever try to blow smoke in your face and convince you that I am trying to give you a medicine that will work on your serotonin receptors, because I know that that's what's the problem. That's just, all right? So be mindful of that. And the challenge in psychiatry as well is, remember I talked about fads and lurching to ideas. I can probably reduce this table down to its atomic structure. I can, or with an atomic microscope, right? You could probably figure out what this is made of down to the atomic level, right? But I could probably never, I believe, help you to understand that when I rub my hands on this table like this, it brings back memories of my rubbing the skin of my first girlfriend in college. No, I'm sorry. But you understand the human experience cannot be reduced to chemicals. And that's part of the challenge because you're taking care of me. So you can tell me all you want, this is made out of certain electrons and atoms. It's irrelevant to me. It reminds me of that first girlfriend, whether it was a good experience or a bad experience, right? And so that's the reductionist approach, which has some value, but isn't totally explanatory. So another definition of a psychiatric disorder, definition, not example. No? Okay, so this is, I don't want you to feel put upon because when I talk to psychiatrists, not psychiatry residents even, psychiatrists have been working in the field for 30 years. And I would also ask you now to step back briefly and think about the absurdity of that situation. It's absurd. Would you ask a cardiologist what the definition is of a cardiological illness? No. Well, self-defined, right? Or a nephrologist. It's very self-explanatory, right? Only in psychiatry can we say we have this struggle, but nobody has even thought about it. So how can a psychiatrist who's working 30 years and I say, well, so what's a psychiatric disorder? They'll give me the names of psychiatric disorders, but they won't tell me what the definition is of it, what defines it, what makes it mine, what makes it under my field, because I was trained to take care of it. Well, that's kind of a backwards way. Oh, because I was taught to take care of schizophrenia, that makes schizophrenia a psychiatric disorder. That's not a flaw. That's a reactive way of thinking of something. So the definition that I was given and that I was taught and that I was drummed into my brain was a psychiatric disorder is any disorder that affects your thoughts, your emotions, and or your behavior. So you now have to wrap your brains around that one. Because that's life. Yeah. Right? That's everything.
It's everything.
That's everything. But of course, disorder means it's disruptive to your quality of life or it impacts negatively. So it could be anything ranging from a sleep disorder. Well, that certainly affects your thoughts, your emotions, your behavior. To bipolar disorder, affects your thoughts, emotions, behavior. Schizophrenia, Alzheimer's disease, multiple sclerosis. Some affect all three. You don't need all three. But I'll give you an example when I speak to Parkinson's groups. And I start by shielding myself behind the whiteboard because I start by saying Parkinson's disease is a classic psychiatric disorder. And the tomatoes, you know. How can you say that? What an insult. You know, there's this stigma thing, which I want you to overcome and convey as well. How can I say such a thing? I can say it, why? Because everybody with Parkinson's disease has a behavioral disorder. Because a tremor, a movement disorder, a shuffling gait, that's a behavior. It's an observable activity. So it doesn't mean it's volitional. It's on purpose. It's involuntary. It's still a behavioral observation data point. So that brings them to neurology, by the way, and that's that artificial divide. But the other two elements are also very common, sadly, in Parkinson's disease, part of the same derangement in subcortical function of their brain. The lower part of their brain is damaged. That's what's caused the motor symptoms, the behavior. They develop mood-related disorders. Not, here's very important, not as a psychological result of being upset they have Parkinson's. That's a key element for you all to grasp for me, please. And they almost all develop cognitive difficulties. For most of them, it's what's called a subcortical dementia, with a disorder of motivation, apathy, lack of initiative, lack of spontaneity, lack of energy and motivation and stimulation. That is because that part of the brain controls those abilities. So we have all three elements. So from my point of view, Parkinson's disease is a classic psychiatric disorder. Of course, I say that to the Parkinson's group or to anybody. They look at me like I'm out of my mind. And that's because of that artificial defining construct which we have to struggle with. Now, our problem goes back now a little bit deeper. It goes back to demographics. And the demographics are pretty scary. They're pretty compelling. As my friend said from Europe, well, we don't have anybody over 62 because the men are almost all dead by 62. They have a few women who survive. So we have a problem of older people. Demographically, most of them are women. So my world is mostly one of, it's my high school fantasy, mostly one of women. I'm surrounded by women. This is actually one of the four guys, and 2, 4, 6, 8. That's more than mine. My typical population, there'd be 1 or 2 of you guys. The rest are women. All right, you guys would have big smiles on your faces, but it's the nature of leisure world or leisure village or.
That's how it is in social work classes.
Sorry.
That's how it is. That's a breakdown in social work classes.
Well, that's true. The people going into fields too, but it's who's surviving, and there are various different reasons for that. But my world is a world of mostly older women, not entirely, but mostly older women. But statistically speaking, we can also say what happens as we age. And there's going to be controversies in, again, use of language. So the way I was taught was dementia, which is defined as a decline from a previously attained level of intellect sufficient to interfere with your social or occupational functioning. That's what dementia means. Dementia is a decline from a previously attained level of intellectual ability sufficient to interfere with your social or occupational functioning. So if you look at it from that point of view, and you say the cardinal element there is sufficient to interfere with. Because if you say to me, as of course most of my patients with dementia would say, well, your memory is not as good as it used to be, is it, Dr. Steinberg? Of course they'll say that, and I'll say, no, it's not. And it's different. So people come in and they're worried. Many people are worried, I am getting dementia. Often those people, by the way, have a new syndrome that I identified. I have not written up yet. It's called SSAI. Please write this down. This is very important. Selective Spousal Auditory Impairment. Okay? And that's real common. My wife says I have Alzheimer's because she keeps having to tell me to take out the garbage. And whatever. It's very common. That is not Alzheimer's disease. That is not dementia. That's like a high frequency thing or something. I don't know what. But it's true. But most people, the cheap and dirty line would be that if you know you forgot, then it's not really as worrisome as if you forget you forgot. So arguably, most of the people that I am worried about are the ones who were brought in by others. They sit there and they go, I don't really have a problem. My daughter dragged me here and I have no idea why. And we're not talking about severe necessarily. And we'll get to the definitions of mild, moderate, and severe in a moment too, because a lot of this is going to shake your world up a little bit, perhaps. So when we look at the big pictures of the 3 Ds of geriatric psychiatry, and we have dementia, and I gave you that definition, there are 60 to 100 causes of things that cause dementia. Now, age-associated memory change is not dementia, we think. All right, so what is age-associated memory impairment? I come to the door, this woman opens up, she looks familiar. I know her. I've seen her before. What the heck is her name? It'll come to me in 2 hours, it's Beth, right? So that's age-associated, and we all have that. I went into the best one is I'm talking on my phone, and my child, one of my kids says, can you look something up? I said, hold on, I have to find my phone. I don't know where it is, and I'm looking around the house for my phone, and he's like, idiot, you're talking on your phone. Oh, here it is, it's right there. Right? Or your glasses, you went into the living room, what did I come in here for? I know, right? Everybody has that. And after age 35, 40, that is normal. But when you're 70 and you do that, you're going to start going, uh-oh. You won't forgive yourself that you lost your car keys. When you were 30, you lost your car keys also. but you said stupid, I lost my car keys. And when you're 70, you go, uh-oh, maybe I'm getting Alzheimer's. So you have to be able to distinguish those things, or have your family members distinguish what is considered, again, careful with the words, normal changes as we get older. Now, I believe firmly, and a lot of what I'm saying, I hope will be borne out in years to come, but there's a lot that fuels the ideas of what causes dementia. There are irreversible causes, we know that, and there are reversible causes, we know that. And my brain is very categorical, and so there's the two most common irreversible causes, a disease called Alzheimer's disease, another disease called vascular dementia. I think that's more common, by the way, but again, I am in the minority, but I think that's going to change. Vascular dementia is dementia caused by little strokes. Little strokes are caused by all sorts of inflammatory and cardiovascular stuff that happens. I would argue that you have to prove to me that if you have cardiovascular stuff below your neck, why you wouldn't have it above your neck. Prove it to me that you don't, and explain to me why you don't. If you have 3 stents and an open heart surgery and diabetes and peripheral vascular disease, and I'm making a big example, how can you not have stuff in your brain? It doesn't make sense to me. And so some of the changes we're seeing in people with memory deficits that rise to that level of using the word dementia have come into me and been told, oh, I have Alzheimer's, and I'm looking at them and I'm going, I think this is vascular. So it's a different avenue. But once you have a damaged brain, and a damaged brain can be from an irreversible dementia, or it can be, quite frankly, just from getting older. And herein lies that controversy, that when I came up in 1983, there was this big biblical law that said dementia is not a normal part of aging. Not a normal part of aging. If you have dementia, it's a disease, but it's not a normal part of aging. If you have, and it used to be that the disease called Alzheimer's was pre-65, again, that number, but forget it, pre-65. After 65, you had senility. That was before. And then all of a sudden it was, no, the changes are the same that they see in the brains. It's not a normal part of aging. Just in some people, they're unlucky, they get it early. Some people are unlucky, they get it later. But it's a disease. And I'm not so sure that that argument, sadly, will hold up. 50% of people over 85, they are the fastest growing segment of the population, will have dementia. 50. So that means that if we all live to 85, and you look to the person next to you, they're going to have dementia. Not going to be you, but it'll be the person next to you. All right, and we have to factor out some of the guys here. I'm sorry, we won't make it. So yeah, you know, you're talking about an epidemic because the numbers are going up of who's surviving, but you're also dealing with people with significant cognitive deficits, and society is definitely not prepared for that, both financially, training-wise. Very few people are going into the field, and infrastructure-wise. It's just an almost impossible concept to conceive of. And sometimes I joke and I say that the government should start encouraging people to smoke at age 63. You know, if everybody dropped dead at age 64 and 11 months, the government would have no fiscal crisis. We'd have no worries with Medicare. You know, I mean, it's a sick thing, but the bottom line is we've created our own industrially developed set of problems dealing with the elderly. But again, we want to keep people as healthy, and we want to add life to years, I guess is a way to say it. And there are many, many ways for us to be able to provide that. The other side of this coin, however, is the fact that as we get older, our brains do become more fragile, even without the diagnosis of dementia. So those of you know that when you're young and you get a fever of 104, you might be a little cranky, or you might be a little annoyed, or you might not be feeling it at all. But when you're a little bit older and you get a fever of 100, you might be laid low. And why is that? That's because our brains cannot abide things the way they used to. We become more sensitive to things, to dehydration, which is ubiquitous in our folks because after age 40, by the time you feel you're thirsty, you're already dehydrated, and dehydration causes us to not be sharp. You develop other conditions. You develop just fragile brain syndrome. So little things, side effects of medicines. Oh, but I've been taking that pill for 20 years. Why now? Should it be a problem? Well, that could be one of the reasons, but the bottom line is also we're now more sensitive to side effects. There's also the medicalization of problems. Some great. We're taking care of hypertension. I'm entirely sure of the cholesterol approach, but we are taking care of certain things magnificently. On the other hand, everybody around this table might tell me they have GERD. All right, maybe a lot of you will tell me you have GERD. You're too young. You're too young for GERD. But there used to be, when I was growing up, a television commercial that said, "I have agita," and I took it was for my Lanta, I think, or Tums, right?
Yeah.
I can't believe I ate the whole thing. That was the ad, and it was for my Lanta or Tums, right? It was agita. That's what they called it. It wasn't GERD. And you didn't need to take a pill that chemically modified your acid in your stomach to prevent such things. You took Mylanta and you stopped eating the whole pizza and the spicy food. But it's medicalized in that way. And these things aren't a free lunch necessarily. They come with burdens of side effects. So I just want you to be mindful of the dementia thing. So what is TBI? You've heard of that one? Well, that's what it stands for. Those are the initials. But what is TBI?
It's not the same thing as an acquired brain injury.
It sure is.
It is?
By definition.
Okay.
The trauma was acquired.
Okay.
You got a motorcycle accident.
Right.
You had concussions playing football. Of course it is. It's an acquired decline in intellect. So therefore, TBI is a form of dementia. Right. So think about labels, names. Some of them are regulatory. I suspect the TBI thing, when I say, well, this is dementia, everybody looks at me, oh no, my daughter has TBI. Again, there's that same stigma carryover thing. TBI doesn't have some sort of stigma the way dementia does, but TBI is a dementia because it's an acquired decline in intellect. Acquired, because you had a car accident, something happened. You started out at a certain level, you are now declined. But because there are financial channels to pay for TBI, which are understandable, and I get it, it's created this whole industry for TBI, which is just, but they're not necessarily people who know how to take care of people with dementia, just so you know. Because, oh no, that's not Alzheimer's. Whatever that means. Or, oh, they don't behave like an Alzheimer's patient. I have no idea what that means, by the way. So I just want you to be mindful that this is just a term connoting a syndrome which has multiple causes. And of course, you can be multiply cursed with many different causes. Now, once you have a dementia, you also are very susceptible, as I said, to reversible things. And reversible things lead to delirium. So that's the second D. So delirium is an acute confusional state. Now you've all had delirium before. I know Beth has. I know. D. All just remember the 3 Ds, right? So dementia, delirium is the second D. So I know Beth just she goes to Nappertandy's. She has a few too many Guinnesses. She gets delirious. All right.
Spot on.
I know my audience. Well, whatever. She's outed. So delirium is an acute confusional state. Being a little inebriated is delirium. And there's about 60 causes of delirium. It can happen to any of us at any age. But again, once we have a damaged, fragile brain, and just being older makes your brain fragile. Not to mention, if you have Alzheimer's, then you're really fragile, or vascular dementia, you're really fragile. But if I give you a low thyroid, which I will do sooner or later if you're over 65 to a lot of people, or dehydration, which I will do in July because of the heat and you're not drinking enough water, and I will do because your daughter told the doctor that you don't sleep at night and you're going to get Ambien or whatever, Benadryl, even worse, Visceral, even worse, and you will get delirium. So this is a very common thing. The problem with delirium, almost like the problem with dementia, is that, even worse, there is not a final common cause. So there is not much interest in researching a solution to it. So this is a bit of cynicism that I have admittedly developed over the years. There's not going to be a magic pill that I can give you for your delirium. My treating your delirium means treating your urinary tract infection, probably the most common cause of delirium in older women with already a fragile brain, or your dehydration, or your pneumonia. And that's why I said most people who are in the hospital are over 65 for medical reasons. The very nature they're there for medical reasons is probably going to put them at risk for delirium. And unfortunately, delirium is what we call protean in its manifestations, meaning when you have delirium, you can have any psychiatric symptom possible in content, which means you can have yelling, screaming, biting, hitting, kicking, over sedation, hyperactivity. You can have waxing and waning level of consciousness. You go in 1 minute and go, oh, they're perfectly alert and fine. The person goes in 30 seconds later, they're totally out of it. And you'll argue with each other about what you just saw. But that's delirium. It's a waxing and waning level of consciousness, like some of you are demonstrating right now, if I don't wake you up. It's until proven otherwise. If I'm asked to do a consultation in a nursing home or a hospital in an older person, they have to prove to me they do not have delirium, because there are so many multiple reasons for developing delirium, and they've got to have 5 of them at least right from the get-go. The challenge will be the identification is, oh, well, they have a urine infection, and this set aside, oh, their screaming is unrelated to that. That's because they have Alzheimer's. You see? And the arguments will be, no, you as internists or family docs or primary care doctors, whoever, or social workers, you have to identify this is delirium. That means we have to treat the underlying cause and be patient, because a urine infection will take, I don't know what they're doing, 3 to 10 to 14 days for the antibiotics to work. And then it takes a while for the brain to stop reeling from the impact. And you've dislocated them, and they're in the hospital, and the lights are on, the lights are off, the lights are on, the lights are off. People are coming in the middle of the night. And so it's a setup for a disaster. And then because they're screaming, they're going to be demanding medicines for their screaming, medicines for their not sleeping, medicines and a psych consult for when they come out of it up briefly and they go, I'm going to kill myself, and then they fall back asleep. They get a psych consult because they said they were suicidal, right? I mean, you've all experienced all of these things, and the problem is everybody's decompartmentalizing things into symptoms instead of syndromes. And that's a very important concept that I want you to also feel comfortable with. My job in training people is to help you to switch gears, especially the social workers. I know this is going to be bad. I'm sorry. I apologize in advance. But I had a nickname when I was from Hopkins. They had a nickname for social workers. Exactly. I'm ready for they throw the bottles at me. It's not true here, because look, we got some guys here, you know. But it was folk dancing. It was folk dancing Jewish neurotic women who wanted to talk about wearing Birkenstock sandals and breastfeeding in El Salvador. Okay, I apologize. Boom, it's out there. All right, liberal, bleeding heart, liberal people who are so empathic. They want to understand everything. They want to understand and empathize. I'm sorry. You'll never invite me back again. But obviously, but you get the touchy-feely sense of what I'm saying. You're empathic, understanding, kind people. You went into this field for that reason. The problem is not all of your answers about the question, why is this going on, will be found through your empathy. And that's what I want to help you to see. Because your natural inclination, because we're going to switch to depression in a moment, your natural inclination is to extend a helping hand. The form of the helping kind hand is the form of kindness. But the helping hand itself is not going to change necessarily the form of their disease. So going back historically, one of our challenges in psychiatry is to answer the question, why? That's what you've all come up with. Why is this person acting this way? Why is this person doing what they're doing? That's the first question. The other questions that you could ask are, what is it that the person is doing? And how is it that they have come to be doing it? And there's a little bit of a twist in that. Because when we use the question, why, we're wearing a hat, an automatic hat that we may not be realizing that we're wearing. And that's called analyzing content. And when we analyze content, it means from a, in a sense, psychodynamic perspective, I'm listening to what you're telling me, I'm hearing what you're saying, and I may be myself giving it meaning. I may myself be saying, oh, the reason she's depressed is because, and you've given me all this stuff, because I put it together that way. I've come up with the reason why you are doing or feeling what you're feeling. But I want you to just step back briefly and be mindful, because sometimes that's the right way, by the way. But sometimes it isn't. Just to be mindful that what you are observing is as valuable as why you think it's occurring. And that's true with the illness depression. And I use the word illness importantly because major depressive disorder in the old terminology is a serious potentially life-threatening illness. In the elderly, the statistics vary, but people can argue, I think, that 25%, some of the numbers go 25% of people over 65 develop major depressive disorder. Why do they develop major depressive disorder?
Life changes. Health.
Their brains were fragile.
Okay, you answered the what's going on, you answered the why. You see the difference? You're both not wrong. And so that's an important thing, because when we are raised psycholinguistically, when it comes, we don't ever say, why do you have diabetes? I mean, rarely would somebody ever say that to somebody as a doctor or as a clinician. We always will say, why are you feeling sad? Why are you depressed? That's our normal linguistic thing. But if I told you that 80% of people with Parkinson's disease develop major depressive disorder, and not because they are upset they have Parkinson's disease, that's a key element. Or a majority of people with strokes in a certain part of their brain, a certain part of their brain develop major depressive disorder, not a different part of their brain. So when a series of elegant studies were done that looked at what's called post-stroke depression, what fueled those studies was exactly asking this question. Are we concluding that their depression is because of what we think it's from? You're depressed because you had a stroke. I would be depressed if I had a stroke, if I were in your shoes. Therefore, I've already gone past and moved to a certain approach, which may or may not be right. But nobody tested that until the 80s or so, the mid to late 80s. Very elegant series of studies looked at people with strokes and looked at the ones who had depression and looked at people who had equal reasons to have depression if we were looking at the why, if we were looking at the content. For instance, if you had a stroke in your brain that caused you to lose the use of your left side, We can argue that's pretty depressing, but that's not what I'm talking about. Now, let's say you lost the use of your left side because you were in a horrible car accident and it was chopped off. We could argue that's equally depressing. You don't have the use of your left arm or leg. It's an equal, challenging, psychological, painful burden, right? So when the series of elegant studies were done, they found that it was not related to the psychological burden of being upset, reacting to what happened to you. It was a direct result of where in the brain your stroke was. So if you had a stroke in the right front part of the brain versus the left front part of your brain, the response, I'm not using the word reaction, the response of your emotional part of your brain was different. In fact, there are people with strokes in a certain part of their brain who develop a syndrome of, and I'll use the word carefully, but inappropriate, giddiness. Now, when you visit them and you see them and you're not mindful of this statistic, and they're having a good time, and they're laughing and jolly, and they're doing great, you will walk out of that room because you're social workers, you're human, understanding, empathic, wearing Birkenstocks, the whole bit. You're going to walk out of that room and you're going to go, I hope when I have my stroke, I handle it as well as they are. You're going to put your own method of reasoning into why they are doing so well. You're not going to sit there and go, oh, they're doing so well because it was a left frontal stroke. That's what happens with left frontal strokes. It's not a normal way to think, in other words, from what I'm saying to you. So I want you to just question, be mindful that especially with the illness depression, where we've all been raised to ask automatically, why do you have depression? It's sometimes as wrong to ask that. It's not the right question, like, why do you have high blood pressure? Why do you have diabetes? You got it. Unless you're a doctor and you say, well, the islet cells of my pancreas aren't working so well. You know, I don't produce enough insulin. It's not the right question to be asking. Rather, it's, I want to assess whether you have what we call major depressive disorder. You may tell me it's because I don't sleep at night. Yes, of course, doc, I'm very sad because I don't sleep at night. What you're not seeing is the sleep is part of the depression. The internist you go to will just say, oh, she's not sleeping well, I'll give her a sleeping pill. You may say, I have a lot of anxiety, doc. Are you feeling sad? No, not at all. Give you an anxiety pill. Nobody's putting together the big pictures. And that's why over 30 people a year over the age of 90 in Suffolk County, last I heard, kill themselves. And they do it, these are mostly men, by the way, interestingly, and they do it by very drastic, terrible means. So they are committed to doing this. These are not the younger people who swallow the pills and call up, 5 minutes before and get help. Not the borderline personality disorders, not the multiple suicide attempters. These are people who have all seen their doctors in the 30 days before. They've all reported the piecemeal symptoms that when you put them together would say, oh my God, this guy had major depressive disorder. They didn't know it. The doctor didn't put it together as a syndrome. Piecemeal talked about sleep, about, oh, my stomach's killing me. Oh, but we haven't found anything. There's nothing wrong with you, Mr. Smith. Makes them feel even worse. Not sleeping, not eating. Oh, here's something to help you with your appetite. Didn't put it together. And, oh, I'm not sad. I'm not depressed. So you can have depression without being sad. You can have depression without being depressed. And they do things terrible. They hang themselves. I mean, the image to me of a 90-year-old guy, again, hanging themselves, that's pretty severe. Or going in front of a train. Pretty darn serious.
And you said Suffolk County alone?
Yeah.
Wow.
So, yeah, and it's missed. And this is really the painful part of it. And it's because people are either identifying that they have depression, but then doing the interpretive thing, which I want you to move a little away from, not the explanatory thing. They're saying, of course they're depressed. They're depressed because, and you named a few. But I got to be honest with you, every older person has reasons to be depressed from a young person's point of view. From a young person's point of view, they all have reasons to be depressed. That doesn't cause major depression. If it did, every one of them would have it, by the way. But from our point of view, oh my God, of course, we could fill in the gaps. They're old, they're widowed, they're retired, they don't have as much money, they have arthritis. You can just fill it in, and they will agree with you, because that's how the mind works. Of course I have depression. I have depression because of all these things. So I want you to just understand that while those are very important features, there's always another angle through which we should look at things. There's the analysis of content, which is you're hearing what the person's saying. I'm having marital difficulty. I'm having troubles with my relationship. I'm feeling bad since I retired. That's content. That's what they're saying to you. That's grist for the mill. That's part of your hard work of therapy. But at the same time, wear a different hat, step back, look at the filter of the computer, and realize that behind that screen of that filter, there may be other stuff that you need to peel off like an Etch-a-Sketch and say to yourself, okay, I have to take the temperature of this person. So how do I do that? How do I take the temperature of a person? So my exam style might be very different from your exam style. My job, I was taught, is to get information. I need data. And so while I will do it in a friendly way, I hope, often I try to use humor, I try to put them at ease. But the bottom line is I need to find out the temperature of the person I'm dealing with. I need to do what for some of them, unfortunately, may be the equivalent of a prostate exam. I swear to them, and these are the ones that I worry about, testing their memory is quite challenging. Why are they taking umbrage at that? Because they, on some level, are already mindful they're having some difficulties. The people who don't have difficulties say, sure, doc, do whatever you have to do, because it's your job. So how do we do a mental status exam? I do a very, very structured exam. And that goes against what some of my colleagues do, general psychiatrists often, psychologists, social workers. Sometimes it's, let's sit down over a series of sessions, let's just get to know each other. For me, it's very, very, very straightforward, and I will demonstrate it for you if you want. I don't. All right. So we're going to bring out all the good stuff here. All right. So, hi, my name's Alan. What's your name?
Beth.
Beth. Hi, Beth. Nice to meet you. How was it you came to see me today?
Family service league.
Sent you to see me. What was the reason?
I don't know.
Oh, okay. Well, your daughter's here with you. Is it okay if I speak with her? And is it okay if she stays here with us? It's okay?
Okay.
Yeah, you better be. Okay, fine. So I'm typing, by the way, and I hope you don't mind, but if there's anything you don't want to talk about, just let me know.
Okay.
And we can kick her out too if we have to, all right? Because...
Just don't speak for me.
Well, she's going to do that because I'm going to need her help. So what's going on that's worrying you about Beth?
She's depressed,
Uh-huh,
sad,
uh-huh,
she's not eating,
uh-huh.
she's not sleeping, she's irritable.
Okay, so those are very important things. Now, you used the word depressed, so I won't say it this way, but I would say, because you used a word, you gave me some objective stuff and some subjective stuff, and you commingled them. You said she's depressed, that's your interpretation.
Yes.
That is common, but I would want data. You did say not eating, that's objective. What does that mean? Is she losing weight?
No.
Oh, okay.
Because I eat.
So she's eating enough to not lose weight. That's a
Because I
fact.
eat, she's not in my kitchen all the time.
Well, thanks for
So
telling
she's
me that.
just assuming that I don't eat.
She might, but your clothes have been getting big on you. All right, and she noticed that because she sent me a letter before and told me that. And you said she's not been sleeping. Do you notice that she's up having trouble falling asleep or waking up in the middle of the night?
Both.
Ah, okay, and she snores a lot too, I think. Yeah. Okay, so that's great. So I want to know what's your father's name?
Oh, Jimmy.
And your mom?
Maria.
And are they both still alive?
Father's deceased.
Okay, and how long ago did he pass?
16 years ago.
Oh my. Okay, and how many brothers and sisters do you have?
8.
Are you shitting? Oh, I'm sorry. Are you kidding? Your parents were very productive. Very good. What are the names of your siblings, please?
Oh, my siblings, Jimmy, Michael, Richard, Juan Jose, Jindy, Johnny, and Mariela.
Uh-huh. Is that right, by the way? Because you brought her. Did she get them all right?
She messed
She did, right?
Mhm.
Yeah, I thought so. But that's okay. And where were you born?
Puerto Rico,
And what's your birthday?
July 1st,
And what year was it?
72,
So how old does that make you?
46.
Oh, maybe it does, maybe it doesn't. I'm bad in math. But I'm not just getting to know my friends here. I'm testing their memory and they don't even know it. Because I'm testing long-term memory here. I'm doing it through the back door. And hopefully not a challenging way. Now, you may say, what difference does it make? Why do you care about my siblings? And I'll say, because I want to get to know you. You came from a big family. That's important to me. And I mean that. But I also want to know about how much memory you have and how you're doing with that memory. I want to know if you like mofongo. See, con salsa, see? So we're bonding a little bit over, because I'm already now getting to know a little bit about you. Where did you go to high school? And college? And then you got a master's? Ah, okay, so that's, and, oh, I forgot, are you married? No, I'm not talking to you anymore.
Yes.
You're married. And what's your husband's name? Tom. How long have you guys been married?
13 years.
Very nice, congratulations. Do you have kids?
Yes.
Excellent, how many?
3.
And what are their names?
Zach and Gus.
Oh, good, now, is that correct? Or did she mistake one of her brothers for one of her kids?
Yes.
She might have. So again, I'm always correlating or corroborating. Now, I don't have to do it directly like that because I might see your daughter there already going like this. I'm keeping an eye, she's going. But that's okay. I'm getting to know you. I'm asking you questions. And you guys can confabulate all these answers, by the way. Don't worry about it. It's okay. How much do you smoke?
2 packs a day.
All right. Is that
More.
Ooh, oh, okay, so that's an important fact. I didn't start with do you smoke, by the way. I'm making assumptions, but no judgments about it. I'm just getting, and how much do you drink?
Maybe a 6-pack.
Of what?
Depends whatever's on sale.
Oh, wow, not discriminating, not here. All right, excellent. And marijuana?
Oh, sure, whenever I can get it.
And believe you me, I have to ask all my seniors this now. You have no idea how ubiquitous marijuana has become in the senior. But I am dealing with hippie generation now too. It's come up that way. But I am dealing with the hippie generation, and so we have to ask. And the answers I get, I'm like, are you kidding me? And the answer is no. I smoke every night, and that's relevant.
It's great for sex.
I heard that the other day, and I have to talk to my wife about that. So,
I'm the only guy in the senior complex, so.
and you are a condo Casanova.
Yeah.
And in fact, sexually transmitted diseases are
It's on the rise.
rampant. And I don't even go through the gates of leaving it, but not wearing gloves. It's dangerous. It's really dangerous without penicillin. All right, what kind of work did you do?
I was a social worker.
Oh, did you like your work?
Yeah.
When did you retire?
10 years or 20 years ago.
Who did you work for?
Gerwin?
You worked for Gerwin. Oh, where did that come out? Okay. Wow. Okay, good. See, so I'm getting history. I'm getting validation. Because all of you are going to be great confabulators, which means you fill in the gaps by giving answers that are not true, but I wouldn't know it necessarily because you're darn good at it unless she confirms for me that what you're saying is true, and you'll go, he never worked at Gerwin. He worked at whatever, Islandia or the Arbors or Bellhaven or something. So I'll be getting objective data about that. Okay, hi. So I've got to know you a little bit. Who's your general doctor?
Dr. Smith.
Nice. Do you like Dr. Smith?
Sure.
And what's Dr. Smith's first name?
Jennifer.
Jennifer Smith. I know her very well. Excellent. And what kind of medical problems does she help you with?
She helps me with my high blood pressure and diabetes.
Oh, okay. And what medicines do you take?
Insulin, and I'm not really sure.
Okay. All right. So I like to know that people know their medicines. But again, if you're not really sure, it could be for many different reasons. And I'll have a list of medicines to corroborate. So I'm asking, I'm allying, hopefully in a nice way, but I'm also trusting but verifying. Right? Because you may be on 8 medicine, and you just gave me 2 of them. I wouldn't know that. I check with daughter. I check with the sheets that I have. All right. We've been adherent with the meds.
I'm not sure.
Okay, so we'd have to kind of look at the counts and make sure somebody's doing that. So I just want to ask you a few questions about your memory. Is that okay if I do that? Okay, thanks. I appreciate it. What day is today?
Wednesday?
What month is this?
April.
What's the date in April?
The 10th,
What's the year?
2019.
What's the season?
Spring.
Right, good. What's the name of our president? I always get a grunt, but that's okay. What's his diagnosis? No, okay. But what's the name of the guy who came before him?
Obama.
And what happened to President Kennedy?
Not sure.
You probably don't because you were born too late and where history is lousy. Okay, good. But I will ask. Alice, what happened to President Kennedy? I'll ask you.
He got shot.
Where? Don't say the head. That's a very concrete answer. It tells me something right away about your brain. All right, because people say in the head. And I'm like, so where was he when he was shot?
I think in a car
Where was the car?
on the street.
Where was the street?
I don't know.
Okay, and that's okay to not know, except most people of the generation that I'm asking should know. So if you don't know, and I've already attained that you went to college, all right? We're not talking about somebody from a small village in Italy or wherever from a first grade education whose English is not great. It's a standard kind of thing. Okay, what happened 17 and a half years ago in New York City?
Towers got blown up.
What towers?
Twin Towers.
And what was the date? Do you really not know, or you're just?
No, I really don't know.
Oh, okay. So that's okay. It was 9/11.
Yes.
But again, I'm going around and I'm gathering data and I'm verifying and I'm picking certain events personally, only because, and this has changed as my generation of patients have changed, cardinal events in people's lives that are sentinel and intermediate term memory. It's not short memory and it's not long memory for them. In a few years back, it was the Challenger that I would have asked about, the explosion in '86, or it would have been maybe Robert Kennedy instead of John Kennedy. So, I mean, I shift that, and that's culturally bound also. I would do that. Okay, good. So far you're doing, okay. Say apple, table, penny.
Apple, table, penny.
Now, I'm going to ask you them again. I want you to remember them. All right? How do you spell the word think? I think of you.
T-H-I-N.
Okay. How do you spell the word hand?
H-A-N-D.
Good. Do it backwards for me, please.
How hard time doing that?
I don't care. Try.
D-N-A-H.
Perfect. So you did it really well. So what I did there was when we have a 5-letter word and we have difficulty with that, I might make it a 4-letter word, or I might make it a 3-letter word. I want to keep ratcheting. Every question leads to an answer. That answer might lead to another question that opens another door. What were those 3 words I asked you to repeat before?
Penny. Don't remember.
And you may or may not really remember.
Right.
But again, that's relevant to me. We just got a 1 out of 3. We had difficulty with reading out of 5 the words. Okay, your turn, sir. Are you ready?
I think so.
Great. Go like that for me, please. Go like that for me, please. Beautiful. Go like that for me, please. Yeah. Now, you could have been a surgeon. Perfect. He does not have any apraxias. That's called an apraxia, by the way. He could have been a surgeon. Perfect. Wonderful. Excellent. I also did not notice any tremors. I'm testing a few things. It's called apraxia, but at the same time, I'm watching the movements. And apraxia is an inability to put things together in visual spatial 3D. But I'm also looking for a tremor on intention. It's called, I'm going to do this one. Now, this one's a little hard. Are you a righty or lefty?
Righty.
With your left hand, I want you to do something. Please. Before you touch your nose, touch your ear. Good. Did you do what I asked? Thank you. Okay, good. So he did that. That's a very hard command because I went A, C, B. I didn't do A, B, C. The mini mental, by the way, some of this is derived from, you're familiar with it. It does A, B, C. It says take this piece of paper in your right hand, fold it in half, and put it on the floor. It's A, B, C. Plus it assumes the right hand automatically. But that's cheating because if most people are right-handed dominant, and they are, they will take something in their right hand anyway, right? So they get a free point. And I'm not in the business of giving free points. I want this to be a test. It's a test. What does it mean when I say people who live in glass houses should not throw stones?
People shouldn't be prejudicial about other people.
Think about half of it. That's the throwing stones part.
Right.
Under what circumstances?
Well, I guess people have to look at themselves.
Correct. That's the glass house part, right? So that's a hard one. And there are easier ones like don't cry over spilled milk. I would have ratcheted it down to the easier ones if we had to. All right, so if 0 was the saddest you ever felt, and this is very difficult, by the way, because this is an abstraction of mood to a number. So right away, I've already gotten a clay. I've already gotten a sense of your cognitive abilities or inabilities. So I may or may not recognize that the answers here have validity. Because most people that I've already established have cognitive difficulties, will either confabulate this answer or have great difficulty even understanding what I'm asking them to do. But you see, how could I even ask you how you're feeling if I don't know if you understand the question? And that's the problem with the supportive, tell me about yourself, how you're doing, what's going on, and why are you here with me today in the elderly. Because I'm sorry to say if 50% of that population have dementia, then a lot of the questions I'm asking, the answers won't have validity and I won't even know it. I won't even know it. And so I'm fooled and I'll be going down that path when I should be going down that path. 0 is the saddest you ever felt. 10 is the happiest. 5 is in between. Where are you on that scale right now? Poor Beth.
She's confused.
She's still delirious from the Abertandys.
I'm happy, so 0 was the happiest.
No, 0 is the saddest
It's
you
the
ever felt.
saddest.
10 is the
Then I
happiest,
would
and 5 is
say
in
an
between.
8.
That's pretty darn happy. Now, again, I would be concerned if somebody had cognitive intactness and truly was an 8. Because an 8 is hypomanic. All right? All right? Yeah, right? I mean, and you might run hypomanic. We will get to that later. So but the point is an 8 is close to a 9, that's close to a 10, and that's the happiest you ever felt in your whole darn life. And coming to a doctor, in general, should not be an 8, no matter what. And most people are either 5, regardless. I'll take a 6. You start telling me 8, either you did not understand the question, and that's important, so I'm not going to give it validity. Or I will then ask other questions associated with hypomania, like, well, you already told me she's not sleeping. Well, maybe it's because of depression. You used that word, but maybe it's not because of depression. Maybe it's because she has. How's your energy? Is it elevated or is it? Do you have a lot of energy? Feel strong?
A lot of energy.
Okay,
Always.
good. I'm glad you think about sex a lot.
Absolutely.
Don't you? Okay, now what I did there was I led the witness, and I don't want you ever to do that. So I gave her the answer. So if she's a high-level confabulator, because we've already established some memory stuff, she might just give me the answer that I led to her. I said, you think about sex all the time, don't you? And she said, sure, I do, yeah. I have no idea whether that answer is true. Truthful won't be the right word, but has validity. How's your sleep been?
I sleep wonderful.
Okay,
My
good.
daughter says I don't sleep.
Well, but
I
you don't
sleep
remember
fine.
that she said that, but that's okay. And how does food taste?
Wonderful.
Okay,
I
so
love sweets.
oh, okay. So people with dementia love sweets, but people with depression find food bland, or black and white, or boring. And of course, unfortunately, most people with depression will be losing weight, or you have to encourage them to eat. But it's not a differential. It's not a make or break, because people with dementia also won't always eat well unless it's prepared for them, right? If 0 was no anxiety and 10 was I'm coming out of my skin with anxiety, where would you be on that scale right now? 4. Okay, so you have a little bit of anxiety. And again, I'll be assessing it in the context of I already tested your cognition, right? Do you have any bad thoughts that keep popping into your head and you can't get rid of them? They make you nervous or anxious? Okay, any rituals that you do over and over again you have to kind of do even though you know they're kind of silly or you don't need to be doing them?
Yeah.
You do? What kind?
Make my bed every day.
Well, no, that's not an unusual ritual. Does it take you like 3 hours to make your bed? Oh, really? Well, that's interesting. Okay. So people know what's called obsession or compulsions. Now, there's definitions of these things. And then we'll ask you, what's the definition of an hallucination? No, but I'm glad you volunteered. What's the definition of hallucination?
Believing something is there that isn't.
No,
Okay.
but I'm glad you said that. Good. What's the definition of hallucination?
I guess hearing a voice isn't thinking that's the reality.
Okay, now that's an example. Again, so no, but thank you for volunteering. Okay, so again, use of words, we use them all the time. The newspapers use them all the time. Everybody uses these words. Daughters, and I use the word daughters mostly because they're the caregivers. I'm not being biased against sons, it's just a fact. Will call up and say, my mom's hallucinating again. I'm not going to just accept that the use of the word is the same as I would mean it to be. So the definition of an hallucination is a perception. So it's a sensory experience. It's a perception in the absence of a stimulus. So the absence of a stimulus, so it can be a perception. There's 5 senses that I know of. The most common in the typical psychiatric disorders like schizophrenia would be auditory hallucinations, right? You can have visual, of course. You could have smell. You could have taste. You could have touch. Now, the experience cannot be with a stimulus. So if we're Mrs. Schwartz and we're at Gerwin, where you used to work, and we're sitting at the nursing station and there's a loudspeaker, and we know she has dementia, but she's in her wheelchair there, unfortunately, not in the day program. And the announcer says, you know, Dr. Jones, call extension 3223. And then this lovely older lady says to the passing nurse assistant, oh, they're talking about me. What will happen immediately is that nursing assistant will say, I didn't hear anything, she's hallucinating. We'll tell the nurse. The nurse will tell the doctor. The doctor will say, oh, Mrs. Schwartz is having hallucinations, and she will get an antipsychotic, anti-hallucination medicine. Not an uncommon scenario, but of course that wasn't even an hallucination. It was a misperception. It was a stimulus. There was a voice, there was a real thing that prompted, and she misunderstood it. So we have to be very careful. There's also that challenge when we get to, so it's a stimulus. There's got to be no stimulus. It's a perception in the absence of a stimulus. Now, delusion is something different. So what's the definition of delusion? Ronald Reagan was a good president? Sorry. This is a bunch of social workers, I assume mostly.
Is it
Not Republican, but I don't know if that's true.
the belief of something?
Okay, so a delusion is different from an hallucination in that it is a belief. And that's very, very important because people use these words all the time in the real world. She's delusional. Or they'll tell me my mom is delusional, having delusions. I have no idea what the daughter means by that. So I want to drill into that. I want to find out more. It's a belief. But what's unique about the belief?
That it's not true. It's not based on fact.
So it's a false belief.
Right.
So I say Ronald Reagan was a great president, but does that make that a delusion?
No.
Why not?
It's an opinion.
Well, but a belief is an opinion.
Mm.
It's got to be idiosyncratic and eccentric and unique to the person. So this is challenging because we all deal with people from different cultures, cultural backgrounds, and we have to distinguish our own personal biases about what's a normal cultural thing from what's an abnormal cultural thing. And that's where family members are very helpful in saying to me, well, we believe in roots, like in East Baltimore, in the South, there were people who believed in roots. It's like putting a hex on somebody with these things. And I'd have people who believed in roots, but their families would say, that's not how you do roots. In other words, they were off, the family was able to identify it as wrong, as delusional. That's not what roots does. That's not how you do roots or voodoo or whatever it might be. But it's a belief. It's a firmly held false belief. It is unshakable and it is unique to the person. Okay, person comes in and says to the doctor, I'm dead. Doctor says, you're not dead. Look, here's your EKG. I do an EKG. Look, their heart. I'm dead. Keeps going on and on. I'll show you a CAT scan of your brain, an EEG. You're not dead. Finally, the doctor gets so exasperated, takes a knife and slices the guy's finger, showing him, look, you're bleeding. And the guy with delusion says, well, I'll be damned. Dead people bleed. All right? You can't shake it no matter what you do. It's firmly held, it's false, and it's unique to that individual. Now, it can be challenging to separate hallucinations and delusions from confabulation, because confabulation is filling in the gaps in my memory by giving you stories that are not true. Mom has dementia. Mom comes downstairs. Daughter says, "How you doing this morning, Mom?" Mom says, "Oh, I'm fine." And Dad's doing okay too. I just saw him. He's doing fine upstairs. Mom, Dad's been dead for 20 years. Call the doctor. She's seeing Dad. Not necessarily. If it's fleeting, which confabulation is, it's just a storyline that comes and goes. We don't get all upset about it. We look at it in its context. We sit there and say, okay, fine, we'll take care of Dad later. Why don't you come have breakfast? And that's the end of it. That's the end of it. So it's not hallucinations by necessarily, not delusions, it's confabulation. And that's what those are the very frequently misused words. Obsession. The definition of an obsession, anybody know? Because these are real defined terms. An obsession is an ego alien idea that pops into my head. I do not want it. It makes me anxious, and maybe I need to do something about it to make it better temporarily. But I recognize it as that damn song, "We Are the Champions," keeps going over and over and over in my head, and I can't get rid of it. It's not a delusion. But if I report it, I keep hearing "We Are the Champions." If I have limited intellect, if I have dementia, I might report it that way. Daughter will say they're hearing singing. But it's in my head, it's not in my ears. And there's a difference. So obsessions, obviously you have obsessions with obsessive compulsive disorder. Obviously, you can also have obsessions with major depression. You could have obsessions with dementia. So you can have obsessions with a lot of things. So a lot of the symptoms I just described to you are not specific to an illness. And that's why it's very important to do a structured exam in the way that I just talked to you about. You want to gather the temperature. You want to take a measure of the clay that you're dealing with. You want to know the validity of the answers you're getting from the people that you're talking with. Otherwise, you're going to be chasing all sorts of red herrings down all sorts of wrong paths, and you'll get nowhere. I mean, you'll get to the point where you'll say, I've had this person in therapy for a year and I'm spinning my wheels. I'm going to send them to Steinberg. I mean, you're going to get to a certain point. I would prefer, personally, you get to that point earlier, because while therapy is helpful for somebody with severe major depressive disorder, and I would say it's necessary, but I would say it's not sufficient. Somebody with Parkinson's-related depression, there's a lot of work of therapy that can be done to help somebody with the chronic disease of Parkinson's on many different levels, but it isn't going to touch their major depressive disorder in the same way. So it's important to be able to separate out the why from the what and the how of those elements. And that's what we call the method of reasoning. How are you reasoning? How are you coming to a decision about what this person has? And that's that philosophy that I alluded to for you before. Huntington's was very, very interesting, because before we had a test for Huntington's disease genetically that you would know you had it and you were going to get it. You knew there was a 50-50 chance because one of your parents had it, but you didn't know. Every single one of the people who got the choreiform movements, the Huntington's disease, before they even developed that, all developed some sort of either mood or psychotic disorder. So that meant there's something in that lower part of that brain that starts to change even before it becomes obvious in a behavior way. It becomes obvious in a cognitive way or in a thought disorder way. But it wasn't because they were upset, in other words, that they had Huntington's. So it's important to be able to distinguish. You don't always get this from this. And important for you to say to yourself, when I reach the conclusion that they are feeling this way because, when you use the words because, you may not be wrong, but you are already using a method of thinking about something that is leading you down a certain path. And you can think about things simultaneously from different avenues. A person can have major depressive disorder, but also be demoralized that they were just divorced. You know, they can be deeply distressed that their son has developmental disabilities. So there are many factors going on simultaneously that you can put different hats on to wear to look at them. Brief thing about other illnesses, special populations. After I'm leaving here today, I'm going to LISH, which is Central Islip. I take care of folks with developmental disabilities. Been doing that for years. Again, to me, the approach is exactly the same. I apply this approach across the board. I have to take a measure of the clay. I have to know what level of intellectual disabilities, because just because you have a scarlet letter on your forehead of dementia or a scarlet letter of MRDD or whatever intellectual disability, there's a spectrum, of course, as well, right? You're mild, moderate, severe, whatever that is. But what percent of people with Down syndrome, that particular genetic one, trisomy 21, develop Alzheimer's? You guys know? If they live to the age of 40 or 50? 100. 100. So now they are living because we're treating their low thyroid, which they used to die from. We're treating their myelodysplasias. We're treating their cardiac abnormalities. They're living longer. I have many people with Down syndromes who are in their 60s or 70s. But guess what? There's a decline. Again, this is the key. You may have started here. So what? We knew what you were able to do with your Downs, but now you're here. But before I say, oh, it's Alzheimer's causing that, because that would be the quick and easy, dirty thing to do, I still have to make sure they don't have any of those other reversible things that I would do for anybody else. Because it could be Lyme disease, it could be their thyroid, they could be having a seizure disorder. There's something that we've worked up recently that was felt to be very rare, and it was called late onset myoclonic seizures in Downs. Very rare. So rare that the neurologist didn't even know about it. But why was it rare? Late onset. They weren't living long. Now, when I see somebody doing this, myoclonic jerks, and they have Downs and they're a little older, I send them for a video EEG. And they're coming back as having seizures. The staff didn't see it as seizures. The staff saw it as attention seeking. Again, why are they doing that? It's the why versus the what. Attention seeking. You know, they make sense of it because that's what our minds want to do. They're doing that on purpose. Oh, it's the medicine. It's a side effect of a medicine they're on. No, they're having a seizure disorder. And so it's important to always step back and look at the why, the what, the how of all of these conditions. So I've gone on and on and on and on. I only told you a few jokes. What kind of lettuce did they serve on the Titanic? First one wins a prize. Don't know what the prize. Which?
Iceberg.
Yes! young lady in the right corner wins the prize. Iceberg. What? This one's really sick. What kind of candy should they have served?
Oh. What a good group.
That's from our drinker back there. Very nice. Good for you. You got it. Good. How frequently has a six-pack? Well, that's a very good question, of course, because there are different types of struggles that we have with substances. And the challenge I would ask of you, and I am no expert in substance abuse, would be, is it better, worse, indifferent, doesn't matter, the same, if somebody drinks a suitcase or whatever those are of beer just on the weekends? You know what I mean, the 24 thing or something.
I just never heard that phrase.
I think they're called a suitcase when you buy it in 24 or something. I don't know. He knows. He asked him. But the versus 3 beers a night. Versus 3, you know, and that's a whole question of binge versus this, functioning alcoholic versus non-functioning. The whole construct of alcoholism is a challenge, and it gets back to the question of disease. So if I said to you back to dementia, we go back to dementia. I do MRIs on people. Every MRI shows periventricular white matter disease, little white matter spots in their brains. The neurologists, the radiologists almost always dismiss it. They'll say, oh, we see that all the time. That's common. I'm like, yeah, it is common, but it's not normal. And you can't tell me it doesn't sooner or later have an effect because it's in your brain, for God's sake. So maybe that is what's causing the cognitive stuff, right? So we have to distinguish, as another good example, almost, if not everyone in this room is going to develop cataracts if you live to a certain age. Beth, Maybe you, not yet. Maybe no. You're drinking. I don't know what that does to cataracts. Yeah, you're hearing too. Right. Okay. So, but the point is, everybody will. I think it's a normal part of aging. Remember that expression I used before. Normal part of aging. The fact that we can do something for it doesn't change the nature of what it is, right? So are cataracts a disease? Well, the definition of disease is a deranged body part. So I suppose it's a disease to have cataracts, but it's a normal disease. But how could a disease be normal? So therefore, it's what happens when you get older. And therefore, is dementia what happens when we get older? Well, it is to 50% of us if we live long enough, at least. So therefore, is it a normal part of aging or not? So it gets back to revisiting everything I was taught earlier on that it's not, and maybe it is, and what can we do to prevent it? Which is, of course, the biggest question. And of course, there's billions of dollars back to that issue of why doesn't anybody care about delirium? Why don't they care about vascular dementia? Because there are multiple causes, so there won't be a pill, a final common pathway pill. But for Alzheimer's, every drug company is holding out the hope that Alzheimer's is the most common, and there will be one final common pathway that causes the disease that we call Alzheimer's, whatever that is, that will prevent it from happening. And I would argue that that may be the case, but still the majority is going to be vascular. And vascular ain't going to change, except we can forestall it by getting you all to become vegans, by getting you all to be low-fat vegans, by getting you all to do aerobic exercise, by getting you all to make sure your hypertension and diabetes are under control, by getting you all to stop your cigarette smoking, and by getting you all to drink in moderation, whatever that definition means, really in moderation. And we'll probably forestall the accumulation of white matter disease in your brain and inflammatory changes in your body, which are, in my opinion, are probably complicit in the development of those changes. So there are some things we can do. And I think that's important. It's also important to counsel you'll use the word clients, patients. I think you use the word clients, do you? I'll give you a speech on that in a second. But I think you counsel your clients in certain ways, and this is one way you can really be helpful to them going forward. None of them will want to hear from it, but that's separate. That's, your role of leveraging your influence in psychotherapy to help them see the path. Now, you call them clients. What's the difference between a client and a patient? Because that's a very important distinction. Well, in the MRDD world, they were called clients. Now they're called consumers. These words change. But as I've said to you, I want you to be mindful of words. We never use the word clients. And it's not because things are over-medicalized. Well, people think that is, but it really isn't. There's a very big difference, I'd like to believe, between my relationship with my dry cleaner, who I am a customer of. I am a client of his, right? Yes. And he cares about me to the extent that he cares that I'm happy with the job he's doing with my shirt, right? Then my relationship with my doctor, who I truly hope cares about me. And I think that the patient-clinician relationship, which is what you have, is distinguished by the fact that you care about them. You care about them as a human being, not as a client. And not as a consumer. You care about them, and that's the difference. Because that's what defines patient as opposed to customer or consumer or client. They're not buying a service from you, like the shirt. You're helping them, and you care about them. And that is a very important distinction, I think. That's, again, my own little... Anyway, I don't know. I have no idea what time it is.
10:45.
Oh, I just rambled on for a long time. I could talk about the meaning of life, about the Middle East conflict. I could do anything. But any questions?
I wonder if anybody has specific cases or something. Yeah.
Well, Dr. Steinberg, what you just said is very interesting. I think the way we sort of rationalized it in social work school was the taking on the person who comes to see you as more of an equal when it's a psychological issue that you're dealing with, as opposed to a medical issue. Yeah. That person comes into the session with strengths
They do.
with life experiences that only they know.
Absolutely.
They come with things that they've overcome. They come with what am I looking for?
You conveyed it to me. I understand what I believe. I understand what you're saying.
So even though the clinician is the higher academic learner, that you're going to look at this person as still coming into the session with life experiences.
So let me change it for you. You will treat them with respect. That is different than making an assumption that you are equal. Okay? You are not equal. They're coming to you for help. They are diminished. They don't want to be diminished. They are hurting. They don't want to be hurting. They are coming to you for advice and for help. Therefore, by definition, you can kid yourselves all you want. But the bottom line is you're not equal in that context. You are not. You will treat them with respect. You will treat them with dignity. But you're not their equal. And that, I mean, it comes down to a joke now that we have Google and the internet, where I literally have had family members say, patients say, my wife won't let me take that medicine. Why? We didn't know she was a doctor. Oh, she read it on Facebook. I'm like, great. All right. Or your Google search is not the same as my medical school education. Fine. I could pull all that if I want, right? It's not a matter of pulling rank. It's not a matter of being arrogant. It's a matter of acknowledging a basic fact which nobody can legislate or mandate or change. I'm hurting, you're not. Well, you may be in a different, whatever your way is, but you're not coming, as you could say to somebody who's not taking your advice, which happens. You come to me every week, I give you advice, you don't take it, but you keep coming back. So are we wasting each other's time? What are we doing here? You come to me for advice, but you don't take my advice. So what is the point? The point is, you're not going to them for advice. They're coming to you because you have the training. You have the knowledge. And that gets back to a very, very, very powerful word, which you all have been taught in the past, is a dirty word. Paternalism. Paternalism is not a dirty word. Often, it is required for you to behave paternalistically towards them. Not always, but sometimes they have a condition that has robbed them. It has robbed them. It has diminished them of their authenticity. Not of their humanness, of their authenticity. Your job is to restore it. And you can't do that without being paternalistic. And that may mean at times you have to be bossy and firm. You may have to say, cognitive behavior therapy, if anything, according to psychoanalysts, is incredibly paternalistic. Because psychoanalysts, just let the person talk and you wouldn't interfere. You wouldn't say, CBT, you're giving them a list of homework, for God's sake, right? You're saying, you go to the movies 3 days a week. I need you to get up and go to the gym 5 days a week. You're telling them what to do. You're being paternalistic. But the bottom line is, they're trusting you. You've earned their trust, God willing. And you have more knowledge and experience than they do. That's why they're coming to you. And so I want you to be comfortable with that and not look at it as an issue of equality. None of us are equal. I'm sorry. We're not equal. We are all deserving of respect, deserving of equal treatment by the law, of course, deserving of being given the benefit of the doubt. We're not equal. I don't even know where that idea came from. She's a woman. She's not equal to me. Sorry. Right? You're right. People were not created equal in this context. They were created deserving of being treated equally. But there are people around this table who are a lot smarter than me. I'm sure of it. There are a lot of people around this table who are better athletically than me. I am sure of it. There are people around this table who are a lot younger than me. I am sure of it. There are a lot of people at this table who don't have to get up in the middle of the night to go pee. All right, we're not, I don't know, but we're not equal. We're not. All right? So when I come to you because I have a problem, I'm coming to weakened. I need your, I'm sorry. I did, didn't I? This is the peeing in the middle of the night side. All right? That's the prostate side over right there and right there and right there. I don't know. But we're not equal. And that's where that word becomes very, very, very challenging. Because you're in a position to help somebody who needs your help. And therefore you're not equal. They're ill. Or I don't like that word. You know what I mean. But they're not well. And I don't care what anybody says. When you're not well, you're not yourself. I don't care what it is that it is, but you ain't yourself. I had 3 eye surgeries this past year. You didn't want to be anywhere near me. I pushed through it and I did my best, but I was not myself. I was not myself. How could I have been? How could you be? You're not. You're just not yourself. And how you manifest that, how you deal with it, how much help you get, how people deal with you, it's different. And I was the first to admit it. So if I was going to say, I can still drive, I got 1 eye, the doctor said I could drive, but in Florida you need 2 eyes, by the way. I swear to you. That's what they said to me, like this, but you can't go to the Springsteen concert on Thursday night. That's the worst piece of news I'm going to give you. I'm like, you really know how to break my heart. Fine, I can drive with 1 eye, he says to me. I'm like, well, I'm not going to drive because I think that's stupid. That's dangerous. Even though the law says I can, I'll figure out other ways. So what? It's not such a big deal. We'll deal with it, right? Lying face down for 5 weeks was not so easy. And I was not myself. I was diminished. And you get, things change us. And we become different. And that's why I'm coming to you for help.
I understand. I appreciate everything that you said. I'm just saying from a strengths-based perspective, if you approach each person, let's say initially when they come in for the intake, first few sessions, you're thinking, you know, all the things that's wrong with this person and how, you know, I can, you know, make those things better.
Well,
so you're kind of
willing, you're going to help them. All right.
Okay, let me give an example. I don't want anybody to take offense. Young people, we have a
They're all young here.
45-year-old person comes in to see a 23-year-old therapist.
Right.
Fresh out of undergrad and grad school.
Is she cute?
She could be cute.
Okay. I might, you know, maybe
so
2 times a week. 2 times a week.
All right. The 45-year-old person has survived for 45 years.
Right.
Whatever he or she had to
go
through in life.
Right.
You know, what life throws out.
Right.
So, I mean, you respect and appreciate what this person has learned.
And you'll learn from them too.
And whatever he or she has had to experience in their life.
And the 23-year-old will learn from them.
Between being 45 and 23.
Correct.
Just by having lived those
Correct.
days on this earth and things that you will experience.
Correct.
When you get to middle age.
Therefore.
Well, I'm not saying.
Do you need to have cancer? Do you need to have cancer to be a good oncologist?
No.
This is the question, right? Do you need to have suffered from major depressive disorder yourself to be helpful to somebody who's coming to you with depression? That's part of that.
A lot of, let's say, major substance abusers.
Okay, would understand. That's part of it. You're right. They know they've been through it.
You've been through this.
You can really get it. And you're right about that sub-segment, I would argue. But the other things, I would say, should be looked at in a different way. Now, there may be times that, you know, look, I'm not in a position of seeing younger people like I just said, right? But I do have people who, and that's part of that counter-transference thing where I'll see a 90-year-old and they'll be like, oh, you're the age of my grandchild or whatever. I mean, it used to be when I started, they were the age of my grandparents. And then they were my parents' age. And now all of a sudden, it's like really weird, right? But some of them I still see, they'll say, you're a kid, they'll say to me. How can you understand? I'm like, I'm here to help you in any way I can. And I appreciate very much that you're giving me that opportunity to be of help to you, and I hope it works. I hope I can. And I hope that the nature of the things that you're going to be telling me are not going to be impossible for me to work with. At the same time, I will be learning a lot from you. And I will be hearing stories from you that will teach. I mean, I've heard stories that are unbelievable. I mean, you know, about growing up in when I started, I had people from the Spanish-American War. I had veterans from the First World War when I was starting. I had people, you know, they grew up in New York poverty, you know, and cold water flats and no water flats and outhouses and ice boxes, of course. And, you know, it's a whole, immigration stuff and coming in steerage and horrible boats and discrimination. I've learned an incredible amount from my work, which has been a great opportunity for me to become more knowledgeable and sadly, I hate to say it, I use the analogy of an oncologist, my eye surgery given me more understanding and a better understanding of all of my patients who, almost all of them, have glaucoma, macular degeneration, visual difficulties, I have a better feeling about that. Yeah. But I didn't need that to happen to understand what it would be like. Or to be of help to them for the reason they're coming to see me. And so I just want you to separate that concept out, that you are in a special position.
Yes.
And it's a powerful position.
Yes.
And you will never exploit that because that's very important. You will use it, though, that power to help them. And sometimes that's the X factor in therapy. Did you read Persuasion and Healing? Did any of you have that book in social work school? It's an older book by Jerome Frank, who was one of my professors. He's passed away since. And it was called Persuasion and Healing. And his thing was, how come psychotherapy works? How come different kinds of psychotherapy work? He wanted to find the X factor. What was the X factor that made psychotherapy effective? And he went through around the world. It was like a cross-cultural review of various kinds of psychotherapy. And, you know, what was the common denomination of factor? And really, ultimately, what it came down to was the relationship you have with that person and ultimately your power over them to convince them, to get them to move in a direction that was healthful. Not helpful, of course, but healthful to them. Which, sadly or not, can be exploited by a bad person. So we can't, and no matter what anybody says, we can't legislate equality in this regard. They call all of us healthcare providers. What is that nonsense? Right? I mean, it's nonsense.
Yeah.
It's ridiculous. Or the worst I hated was, of course, HMO, Health Maintenance Organization. As if, putting aside what I said about treatment of chronic diseases, there is anything in this world that I can do to prevent a good person who's done everything right from having a heart attack. We're not God. Health maintenance organizations don't prevent illnesses. Stuff happens. Sadly, it just does. And when it happens, then we can help people to deal with it better. So, but we are in a powerful, but we're not, this whole concept of we're a team. I get that construct, but it isn't a truthful statement because we're not an equal team. I have patients who are doctors who come to see me. They're not doctors in my office. They're there for my help. Mm-hmm. I treat them with respect. Again, it's not the issue of how to treat somebody. It's the issue of I am not dealing with what you're dealing with. You're coming to me for help with that problem.
We have a question from one of our...
A question from the audience.
Yes.
From the nether.
Is the client-centered approach to treating an individual with dementia a more effective approach in light of memory limitations?
Okay. So it all depends. I did not touch on mild, moderate, and severe.
Okay.
Because the answer will depend on that.
Okay.
So let's describe mild, moderate, severe. The Folstein mini-mental state exam, which I did partially, I did a modified version of cognitive testing, sadly has transmogrified into marker associated with the words mild, moderate, severe. So if you have a mini mental score of, let's just say 25 or 23, you're mild. If you're 14, you're moderate. If you're below 10, you're severe. The number translated into severity, I disagree with that, because the bottom line is I have people with scores of 30, meaning the score is normal, who have severe dementia. So that's a very important point. And how can I say that when I see somebody who looks really darn good to their family, and I get what's called the jaw drop moment, when I say, I'm sorry, but you know, your mom has dementia and it's not mild and it's not moderate, it's severe. And the jaws go, but she's still driving and she's still cooking. And I'm sitting there going, and she shouldn't be, and she shouldn't be. And I say, let's change how we define it. How much does this condition impact her or his ability to prevail as a successful, functioning, independent member of society? If it affects their ability to prevail severely, then it's severe in its impact. That defies the image we have of the person in the nursing home with severe dementia, because that's the physical decline stuff that we're observing there, which goes hand in hand with cognitive decline. But you can have people with cognitive deficits that are very subtle, but are still severe, God bless you, in their impact. They shouldn't be driving, they shouldn't be living alone, they're messing up their medicines, the families are pulling out their hair, they're non-adherent, they're gonna get sick every other day because they're not taking care of themselves, but they still argue a good game, they still confabulate beautifully, they refuse everything that everybody suggests to them, and it comes down to paternalism and autonomy. And so when I say our challenge in this society is that one of the first questions that is always asked here, and you see it posted everywhere, and it's in subtle ways, and it's in black and white ways, and it's in, what are the patient's rights? It's the first thing. And I sit there and I say, what's their capacity to exercise their rights? That's the more important question that should be asked. And of course it isn't until you come and ask, but New York State doesn't ask that question. Patient has a right to choose their own doctor. They have no idea who the doctor even is. So what are you doing? Right? So what's the other way it's addressed in other countries that are democracies? We'll choose democracies, not tyrannies or whatever. In other democracies, European countries, Israel, France, Germany, Italy, whatever, England, Iceland, so I could say their first question is not what are the patient's rights? What is our duty and obligation to them, given that they've been impacted in this way? It's our obligation. So when a nurse says to me, she refused her medicines, I say, I don't want to ever hear that word again. She doesn't have the capacity to refuse, because she doesn't even know what she's taking. She doesn't have the ability to consent either, by the way. She can assent, but not consent. You failed in getting the medicine into her. You were unsuccessful in getting the medicine into her. The burden of responsibility shifts. And it doesn't mean you're a bad person. There could be great many reasons you were unsuccessful. But the bottom line is the burden of responsibility is on us to care for those who are weaker than us in society. And so when you talk about the patient-centered approach, it means, yes, everything, of course, should be patient-centered, but everybody's an individual, and everybody needs to be, their temperature needs to be taken the way we talked of it before, because sadly, the label is meaningless. You can have dementia, but it doesn't affect you in this level, this level, this level, but it affects you in this level. So it has to be tailor-made to that particular need. But at the same time, most of the patients that I take care of with dementia, we do a lot of work with social work, with nurse practitioners, working with family members, because we need to enlist the help of structures in our community, daycare, scat bus, reliance on home health aides, on companion services. The single most important thing I can ever recommend is daycare for people with at the very least moderate to severe dementia. Often it's a big struggle to convince, but keeping people active and engaged. Well, my mom was never a joiner. This is the most typical answer I get. Well, I don't care. Right? I mean, I don't, yeah, I really care, but I don't care whether she was or wasn't. I know what's good for her now. And that's paternalism, right? I know that if she's in a warm, loving embrace of people who care about her, and she's going to do horticulture, and she's going to do dancing, and she's going to do music and singing, and she'll get a good meal, that's thriving, given her limitations. Sitting in the dark, in a chair, in her bedroom by herself, That isn't life. So let's think about what they need and provide it to them as a burden of obligation, of duty to them, not in any other way. So you have to also not just be patient-centric in terms of it's an individual thing that unfortunately often they are moving targets and they will be predictably unpredictable and they also will progress over time. But we also have to work with the system around us, whoever it is, whether it's patients, families, or relatives, or sometimes well-meaning neighbors. We have to be careful to be protective, of course, of the strangers that may come into their lives. I've learned to be a little cynical of love sometimes because I've seen it all. But you know, it's our obligation to be protective of our people when they've been robbed. Now, you could say, but can a person make a decision that's bad? And I would say, yes, this is America. You have the right to make the stupidest decisions in the world as long as you have the capacity. But if I found that you lack the capacity, then you've lost the ability to make that stupid decision. This typical one would be the cigarette smoking one. Cigarette smoking one is they come into the dementia unit, let's just say, and they've been chain smoking all their lives, and their family's still buying them cigarettes, and it's an old habit. I don't mean just old habit, but it's an old ritual that dies hard, not to mention the addictive component of it. But the bottom line is, we have an obligation to protect their health, not to give them cancer sticks. Oh, but they always smoked. They always knew it was bad for them. And that's true. They did, and they made a decision to smoke. But now they no longer have the capacity to know the risks of smoking. And just because they did in the past doesn't mean they can assess the risks and benefits, if there are, of smoking today. Therefore, it's the paternalism issue. We have an obligation to protect them, to take care of them. And you wouldn't let a 4-year-old smoke just because they see cigarettes, right? Well, you might, but you know, you're not supposed to. And so essentially, if they've been robbed, you have to establish that temperature first. That's why I went around and I did cognition first. It was sending you a message. You need to know what clay you're dealing with. They may talk a great game. You may say, oh no, they're alert and oriented. They're perfectly fine. They know exactly what they're doing. That's the most common answer I get from nurses and people. They know exactly. And I test them, and there's the jaw-dropping moment where it's like, oh my God, they're really much worse than I realized. So.
But you mentioned substance abuse before, and this comes up sometimes where we have people with terminal illness, right? We know they have a very short time to live, and we know they have a problem with maybe alcohol or substances, and they were pot, and they like to get high.
Right. Or chocolate sundaes. I mean, I mean, it could be anything as far as I'm concerned. There you're talking about, at what point does it provide them a medical benefit or a pleasure benefit is what you're kind of sliding into.
And is it our responsibility in those cases?
It depends what you mean by terminal. It depends what you mean by imminent. It depends what we want comfort care at the end of life. I also work at a hospice, so I'm very familiar with the whole notion of comfort care and hospice care. And I'm also comfortable with the notion of having in-laws. Oh, there's no HIPAA here because they're in-laws, who are well into their 80s, who drink perhaps more than I think is advisable. And part of the family says that's their one pleasure they have now. At 5 p.m., they have their togetherness thing, their cocktail thing, right? That's a very common thing. So what are you going to do? I'm going to be like, take it away from them? You know, I don't know. And so there's not a yes-no answer to that one.
Because some of the facilities have like
happy hours. That's a disaster because 94% of people in those facilities have dementia. So you're already dealing with a weakened brain, and it isn't a right to drink alcohol. There's nothing in the Constitution that says you have a right to alcohol. Okay, so that's a total conflates my job and makes my job harder because it's just going to make them confused, more confused. Now you can give them placebo stuff. They can have duals, or they can have a very watered down gin and tonic, and they probably won't know the difference, and that's okay. But free access is dangerous. Now it's different though when you say terminal, and terminal. To me, in hospice, of course, is pain relief. Our job is to give people comfort and pain relief. And from my particular perspective, short of making them delirious, which is often the end result of what happens from the morphine, it's an inadvertent hastening of death. Right. It's inadvertent. Nobody's doing the physician-assisted suicide thing. But it's inadvertent that you keep giving people morphine, they're going to get delirious. but they have 3 days left to live and they're in agony, they deserve to be comfortable and free of pain. So it's one thing, again, to say they enjoy their scotch at 5 p.m. and it's not killing them right now, we hope, versus they really need morphine or whatever. I mean, we can substitute medical pain stuff for illicit stuff too, obviously. So I'm not black and white about that. It's a very individual focused idea. Any other questions?
So from an assisted living perspective, I'm saddened by our discussion.
Okay, sorry.
Because I feel that I have less impact on them. And I'm not a medical professional, but to help them. Like, we have people that obviously start having dementia as they're living with us. First started 15 years ago, it was a little bit more, in my opinion, a little bit more black and white dementia versus
Correct.
Psychological issues. And now it seems it's like so entwined, I can't tell the difference.
That's, and you shouldn't, because 95% of the people, at least in assisted livings, have dementia. It's not recognized necessarily. It's not labeled. Oh no, those people, they don't have dementia. They're okay. Those ones are in the unit that has the sign on the door. And so sometimes I kind of say that you're running a tertiary care psychiatric facility, and you are, because they have 95% of them have psychiatric disorders, which is the dementia, and they're getting into trouble because the setting, the Gen Pop setting, we'll call it, is filled with people who have dementia, but they're good enough to pass, but bad enough to get into trouble. And that lineup at the dining room at 5 p.m. is a nightmare, because they're like 8th graders or worse in junior high school dining room, right? And it's too stimulating and it's too big, but can you help them? You can. And I'm not saying necessarily your job is to be the one who medically helps them, but environmentally, well, you may have limitations by your uppers on what you can do. But I was involved in the development of a dementia program in Tennessee, where it's assisted living, so it wasn't SNF, 100%, they had an independent, and then they had 100% dementia units, we'll call them. They were architecturally designed optimally. They were pods that were in a circle. And in the center of the circle was a garden. And every point had an access point. There were no locks on any doors. The doors that people got out of, the staff, were hidden, so nobody could see them. So the patients never felt, I got to bang on the door and get out. They could always wander out into the garden if they wanted. Every pod had a different theme. So this theme was horticulture, and they had people from Vanderbilt. We had people from Vanderbilt come and do gardening with them. And this theme was music, and this theme was history. But you could wander with nobody cared if you wandered, because it was safe to wander. Every pod had a kitchen with staff there who, if they wanted to help and they felt they could help, feel useful to help with cooking. Their use of medicines was dramatically low for agitation. They had animals that were bred to be therapy dogs that lived there, didn't just come to visit, cats and dogs that lived there. And so it's home. It's not threatening. It's not challenging. It's comfortable. They walk around. They see familiar faces. Everybody knows everybody. And rarely is the word no said. See, and that's where the challenge comes.
By me, it's always no.
It's always. And no provokes a response.
Right, and the next call is, all right, well, the psychiatrist.
Exactly, because they need more medicine for this. And it puts us in a very difficult position, because sometimes I say, well, look, it's normal for Mrs. Jones to be stripping in the living room. There's no pill for that. Please take her to a place where it's more dignified and get her changed. And, but there is no place, because the environment is retro-patched.
And the doctor's done 5 minutes with it. It's like,
it's a frustrating, and that's why I don't go to assisted livings anymore. And I don't go to nursing homes anymore. And, well, that's a separate issue. I've been, for years, I've been trying to find another. There's just nobody going into our field, which defies the business model of logic, but not the money side of logic. There is no money at all. Behavior follows dollars. We were talking about it's socialized medicine, and Medicare is essentially very, 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 very bad when it comes to geriatric psychiatry services. So a lot of people aren't going into the field, and it's a train wreck, and it's getting worse. So in assisted living, you bring a smile to a person, you'll change your horizons, right? You bring, just like in a nursing home, when people say to me, how can you come here every day or whatever? Well, like you get used to certain things, of course, but then you say, well, I bring a smile to somebody's face. I mean, what's my goal, right? My goal is to make their day a little better. Exactly. You're not looking to save a life, right? Or whatever it may be. You're making that this second in time is a little bit better. And that's worthwhile. It really is. I know it's frustrating. And
it would be nice as an industry if it would wake up.
I've tried my best to offer the Tennessee idea.
Full ego and
I
profit.
hit walls of we're doing it fine the way we are. We don't need your help is a typical answer. And they're doing fine financially right now. There's not enough competition based on programming.
Yeah, now it's starting to.
It's starting. And so, and family members are starting to hopefully ask, like, what are the guts of your recreation program? Because those guts should be 24/7, right? I mean, really, because there are people who have sleep-wake cycle disturbances. Big deal. You know what I'm saying? If they can be engaged in an arts project at 2 a.m, what do I care? If they're happy and they're good and life is, life is right. But I go to Sunrise and I try to offer them, we're doing fine. Cookie cutter. We're fine. We don't need your help. We're fine. We don't need your help. All right. So maybe someday there'll be enough competition that the daughters won't just look at the china or the chandeliers,
how pretty they are.
because that's what they, and they'll look at the guts of, well, what are you doing with my mom at 3 a.m, or they don't.
Look, look at the staff. Look at the things that matter. Because these are the people taking care of your mother and father,
Right.
not the physical.
Right, the amenities.
And what kind of training do they have? We've offered training programs. Sometimes they've been
Emotional training.
right. Well, they claim, there's like, oh yes, we have an orientation.
Yeah.
You know what I'm talking about.
We do it all. We do all we're supposed to
Right,
do, but it's really not even close to
And
it
I'll
all.
tell you what this place in Tennessee has. This place in Tennessee has, we decided, embedded behaviorists. So what that means is on this pod, there's not a psychologist, maybe master's level or a college, that's fine. They're trained, they know it, and they're just walking around. And when they see a nurse's aide interacting and they just observe maybe a comment or this or that or a way or a style or a posture, they might go up to them right in that moment and say, hey, why don't we try it this way? That's the teaching moment. A lecture about it just goes this far, and that's that. So I'm still available to do training. You can tell all your people at the Arbors, at Sunrise, at Bristol, at the Ritz, at wherever. We're still available. They're opening assisted living.
Really?
Oh, yeah.
What's the name of the Tennessee program?
Sorry?
Does the Tennessee program have a name?
Abe's Garden.
How far away do you do training?
I'll go all over the world. I'll go any medical school or any assisted living program around the country that wants to set something up.
I also read an article that said they are encouraging assisted livings to have doctors on staff.
Well,
And based on what we were talking about, it doesn't sound like a bad idea.
there's a plus minus to, we'll call it a closed shop versus an open shop. So some nursing homes have a closed shop, like Irwin is closed, meaning they hire the doctors and that's their job, right? And others, nursing homes are open, meaning the doctors come every 30 days or 60 days, and the nurses, it's really a nursing home, the nurses run the show. There's pluses and minuses. With the doctor always there, you get a certain clientele that expects their parents to be getting a certain level of medical attention, like her nail was cracked, the doctor needs to see her kind of thing.
Oh, yeah.
Oh, right, or over-medicalizing things or over-treating things. Granted, they may identify things earlier, which is good too, but there's a flip side of that. So, there's...
It's nice if they had that more global look at things, but that takes time too.
It takes time. And look, Abe's Garden it's only $6,000 a month, by the way, which, is so shocking to me because I'm used to, New York, and it's crazy because it's doable. I mean, granted, Nashville's not inexpensive, but it's not New York pricing, and you can get staff for less and all that, but the staff are treated very well. I know that for a fact. I know how they're incentivized to not take days off. you know, in a sense, because they know they've done an analysis of what are the most common times. You know, people don't want to be held for a double or whatever it's called, and that creates a whole lot of trouble. So what they do is they incentivize it. They give it people's choice to when would you like to work a double, as opposed to you have to work a double, and then they have much less no-shows and absenteeism and emergent. I mean, there's all sorts of strategies that they've adopted, and it's less money, and it's doable. It's just these are big businesses. They, you know,
That's what employee appreciation I always put at the bottom because
it should be at the top.
all other things are more important.
It's not. There's
At
nothing
this
more
point in
important.
my life, that's tops for me. And
It's
kudos
totally.
to my
People
community.
will, you know, these are loving people, God willing, that are hired, and they're not getting paid a lot, and they're doing a very hard job, and they will work harder if they feel they're appreciated, and they should feel appreciated, and it just isn't always done that way. People are quick to criticize. What didn't you do? Why didn't you? Why didn't you?
And that
So-
used to be my mentality when I first started, because that's what you taught in school. Well, as I
Right.
say.
It's
And
terrible.
I got killed for years with that
But
mentality.
the problem is if you go outside the box, you'll get into trouble. If you do the right thing, which I would say is the right thing, you'll get into trouble.
Yeah, well,
You know,
that's like my boss all the time.
for
I'm
being-
always in trouble.
It's okay if you do the right, you're doing the right thing to live with yourself. Well,
Well,
thank you all very much. I
Thank you.
appreciate
Thank
your
you.
kind attention. I really do. Thank you. And nobody got too delirious.